Good afternoon, everyone, and welcome to this special edition of Primetime in the BU Library. We don't usually meet in the afternoons, but today we are, so that we can hear from our guests, our Edgren scholars. Primetime celebrates the learning in and beyond the classroom of Bethel faculty, students, and staff, and is a collaborative project between the Friends of the BU Library, faculty development, and other offices on campus. Please join us on Thursday, May 2nd at 11:15, our usual time, as Jolene Pearson, Associate Professor of Early Childhood Education, shares about her sabbatical research on early childhood education in Iceland, Norway, Ireland, England, and the Netherlands. Today I'm delighted to welcome you to an Edgren Scholars presentation. The Edgren Scholars Program supports faculty, student, research teams as they collaborate on a research project. The project must be one that has the potential to make significant contribution to a given field of study, and the project must reflect meaningful collaboration on research between students and faculty. The Edgren Scholars Program is named after John Alexis Edgren, the founder of what is now Bethel University. One of the key educational principles that Edgren articulated in the 19th century was that the relation between students and pupil shall not be that of commander and subject, but one of true friendship and helpfulness, right? Right. True friendship and helpfulness is what we're all about, and it's in this spirit that we established the Edgren Scholars Program in order to encourage and facilitate students and faculty working together. Today, Doctor of Nursing Kristin Sandau and senior nursing student Karin Karin Canakes will be sharing their collaborative research project with Cedars Sinai in California on living with a left ventricular assist device. Thank you for being here. Let's welcome them.
Good afternoon. It is great to be here. Thanks for coming. So my background is I'm almost 30 years as a registered nurse in acute care, and almost all of those years have been in cardiovascular. My background academically is undergrad at Bethel University, and I see my previous dean. I want to say Dr. Mosman. I don't want to call her Judy, but Judy is here, and that's exciting as well. It kind of comes full circle. Then and then my doctoral work is from the University of Minnesota.
And I'm Karin. I'm a senior nursing student here at Bethel. I'm graduating in May, and I am super grateful to have gotten the Edgren Scholarship for this summer. Got to work alongside Dr. Sandau, who's been my professor for a couple different classes throughout my time in the nursing department, and I got to do my senior capstone in the cardiovascular ICU at Children's Hospital, so I got to see some of this work that we've done firsthand, which has been really exciting.
So today we're going to talk about our work that we have been doing with Cedars Sinai. For a brief background, we have over 5 million, closer to 6 million people in the U.S. with chronic heart failure, and there is no cure from that outside of getting a heart transplant. And as you might imagine, there's a limited availability of donor hearts. And so this leads us to the continual development of artificial or our devices to work with people with advanced heart failure. So Karin and I are focusing particularly on patients with a left ventricular assist device, LVAD. Originally, the protocol for this study was going to also look at patients with a total artificial heart. So we'll talk just a little bit about that because it's so fascinating. And then we'll talk about why that part wasn't able to happen. When you look at the literature, a lot of the studies are on morbidity and mortality for patients with advanced heart failure that have a left ventricular assist device. And we need to go beyond that. We need to go into what is the experience like for the patient, what are their challenges, what are their strengths, and how can we help meet the needs of the parts of their life that are harder then. So looking at quality of life with the potential to identify interventions to enhance self-management with the complex condition and device. So the purpose of this study was to take a look at the perceptions of self-management and quality of life living with an LVAD, and that was our focus. So we have color-coded. Our focus is yellow, and our teammates, our colleagues at Cedars Sinai are focusing on the green, the perspective of the caregiver then. And then so we're going to be looking at both those interviews of both those sets separately, and then a third project is looking at the combination of viewing those transcripts together then. So the sample was purposeful because it's qualitative, and it has a small sample size because in qualitative you are looking specifically, I see some people nodding, so they've been listening in their research classes. You're looking at a unique experience of individuals, and the data are the words rather than numbers then. And so these were recruited at one of the nation's largest transplant centers, Cedar. And we did a qualitative approach with semi-structured interviews, and the patients and their own selected caregivers, so a lot of times it wasn't a spouse, but it often was, they were interviewed separately in separate rooms then. So we'll get to the results later. So the study was grown out of my friend and colleague, Dr. Bernice Coleman at Cedars Sinai, wanting to do a similar study that we had done here in Minneapolis, at Minneapolis Heart with Dr. Barb Hoagland, another nurse faculty previously at Bethel. And that qualitative report that we did generated a lot of interest, and she wanted to see what the findings would be, expanding it to caregivers and also looking at self-management. Now, when you do study with humans, it's very different than the lab, right? So those of you that are used to doing research in the lab, you can control all your variables, and you've got X amount of a concentrate in a vial, and you can time it for this exact amount of time. Well, when we're doing research with human subjects, there's so many variables you can't control, and you don't want to, because it's their lives, right? And so we want to look at people in their own natural settings and have them tell us what's going on, and it's not about control. We want to know what that real experience is like out of the test tube, out of the glass, in vivo.
Yeah, so just talking a little bit of why we chose qualitative. Dr. Sandau talked a little bit about why it's important to not try and control all these external variables. But I think quality of life in general, that expectation that people have for what their quality of life should be really varies from person to person and depending on their age. So with that device, it's a hard thing to measure, so it's really important to start at least with this qualitative study and just trying to get input from these different patients. And right now there's not a lot known, there's not a lot of studies that have already been done about the different specific concerns that these patients have between men and women, between younger patients and older patients. Most of the studies are done on the typical white older male that is our typical heart failure patient, which does match that overall population, but there also are
It matches the overall population of patients with LVADs when we look at our INTERMAX data nationwide.
Mm-hmm. But it is also missing some of the people that are also included in that population.
So I just want to point out, we actually do have the very first disease-specific quality of life measure for people with an LVAD, and it's called the QualVAD. And Dr. Barb Hoagland and I worked on that with a wonderful team here in Minneapolis. And that's undergoing study right now. We're writing manuscripts. We presented psychometrics this spring, and it's being used in the US and Germany. But wonderful thing about quantitative and qualitative is we can work together, and so the qualitative findings that we get can continue to help us refine and enhance this tool to make sure that we are covering the things that we need to cover. So the first half of the summer, we waited and we waited for the transcripts to come from Cedars Sinai. We were very excited, and they didn't come because we're dealing with humans, and that's totally normal. So there was a little bit more of a delay that didn't exactly fit our timed period of Edgren's study in the summer, and some of the patients that had signed up to be interviewed canceled because of Memorial Day, for example. So we decided we better get busy with something. And so we began a collaborative, integrative review of self-management in LVAD patients with some colleagues at University of Nebraska. And this actually turned out to be beneficial for us because it gave us a larger and a more in-depth background on what is self-management. What are the stressors, complications? What is the caregiver role? And then what are the current models out there already in self-management? So we're still working on that because second half of the summer, we got the transcripts. So we were really excited as we began to receive these. And so our focus was on the patients with the LVADs, as color-coded in yellow, and then we analyzed those with our partner, now Dr. Williams. She was finishing her Ph.D. at Cedars Sinai at the time. And then Dr. Coleman and Ms. Martinez focused on the transcripts of the caregivers then. So then during this time, we had weekly phone calls, we had Skype, and we worked together remotely on analysis of the transcripts. And we started with their analysis of the caregiver transcripts and worked with our initial code book, which were topics and then subtopics, and then looking at themes through there. So that we would have the similar topics and subtopics in our database then. So we're continuing to synthesize those results because then we started a very busy school year. So we have the first level of analysis done on our transcripts.
Yeah, so just talking about a little bit of background for this study and explaining a little bit about what heart failure is and why these patients need LVADs and that process. So heart failure is when your heart muscle isn't pumping as well as it should be. And when this muscle isn't doing the pumping job that it's supposed to, all of that fluid that it's supposed to be pumping gets backed up. And it gets backed up into the lungs and into the patient's feet and lots of different places where it's not supposed to be. So heart failure can be chronic, where it's continuing ongoing, it's over time, or it can be acute, where it's starting suddenly. And it can be right-sided or it can be left-sided. And it typically starts on the left side because the left side is what pumps the blood to the rest of your body. And when that pump is bad, that's when you get that fluid back up. So if your right side isn't pumping well, you get fluid back up into your lungs. And if the left side isn't pumping well, you're not pumping enough blood to your body.
So the left side backs up into the lungs. She's got a visual here.
So this is just some of those different symptoms that you see with heart failure. You see fatigue, restlessness, confusion, when the blood isn't being pumped to the body, and then this is when the blood is backing up, depending on which side of the heart is not pumping as well as it needs to be. So some of the numbers around heart failure, 5.7 million adults in the United States have heart failure, so this is a condition that's really important to be studying and to looking at different ways of treating this. Heart failure is costing the United States an estimated $30.7 billion each year in healthcare costs. It's the most common reason for hospital admittance for patients 65 and older. And for 1.4 million people with CHF are under 6 years of age, so it's not just that older population that's being affected by this. There's 550,000 new cases each year, so it's something that's continuing to be an issue over time, and half of the people that are diagnosed with heart failure will pass within 5 years of that diagnosis, so it's something that really needs to be addressed. And so there's a little bit more background of different ways that you can manage healthcare, or that you can manage heart failure. There's medical management, which you can have different drugs that decrease the workload of the heart by opening up those arteries, different ACE inhibitors and beta blockers. But then there's also drugs that are used to treat the symptoms by pulling off the fluid out of the lungs or pulling the fluid out of the dependent areas. And then there's also drugs that can be used to increase the strength of the heart muscle in order to help that pump work a little bit better. As well as different lifestyle modifications, working on smoking cessation for patients that smoke, trying to reduce the amount of sodium they're intaking, taking daily weights, trying to monitor that fluid status and staying on top of it, including physical activity into their lifestyle, and then trying to manage their stress because their stress will be affecting their blood pressure. So for the patients that medical management isn't enough, like we talked about, the only definitive cure for heart failure is a heart transplant to get a new pump. And so for patients that meet this criteria where medical management isn't enough, The options are either the left ventricular assist device, which is what we've been researching, and then the total artificial heart, or to get a heart transplant. And like Dr. Sandau said, there's not a great availability of heart transplants for these patients. So really looking towards device management and using those devices to work with these patients. So a total artificial heart. It kind of sounds like a crazy idea that these are placed in people and they really do help their heart function. So for a total artificial heart, you're actually removing both ventricles and placing this device in place of where those ventricles are. So the total artificial heart is both the left and right ventricle, as well as all 4 of the heart valves. We have a video of that. So this,
That is put inside the backpack. And the batteries, extra batteries would go on the outside.
I'm going to pause in just a moment so you know the context. This is at a vendor stall at the International Society for Heart Lung Transplant, and I'm trying to give a quick run through of what it looks like in terms of, you just saw the equipment outside. Did you hear that clicking with the pump? And then this would be the backpack that the patient would wear.
15 pounds at least.
Let's do it first.
so having seen and heard of total artificial heart, what would you guys think your thoughts on quality of life with this type of device would be? What would you guys' concerns be?
What would your questions be to your providers, or how would you feel about receiving a total artificial heart?
I know a lot of patients who have like an artificial valve will hear the sound clicking, and having like all of your valves be artificial and hearing that clicking all the time wouldn't be very fun to live with. That's my initial thought.
So Haley's initial thought is that when she's taking care of patients that have a synthetic heart valve, they might hear that when they're lying in bed, that click, and that's normal. But that to magnify that with constant clicking for more than one valve would be kind of maybe disconcerting, or how would you describe it? Okay.
I just would always hear it in the back of my head and feel like it would just be kind of unsettling.
And maybe unsettling. Okay. Anyone else?
Do I have to wear that backpack everywhere?
Yeah, do I have to wear the backpack everywhere? Yes. And this is actually an improvement. This is about 15 pounds. In the past, you would have to carry a cart behind you. So a lot of ways that your life would be impacted, right? So for the better, you're alive, and you're feeling better. You're able to probably, hopefully, start increasing your activity, but a lot of other parts that would be different than your life prior to a total artificial heart. And one thing that Karin and I want to mention is, so initially when we were working with Cedars to do the study, some of the patients interviewed in a separate group were going to be total artificial heart patients. But there was a voluntary recall of all the total artificial hearts by Syncardia because of a faulty driver prior to our study beginning. And so these patients had to get emergently transplanted. And then we lost our pool, our sample, when size went to 0 possible candidates for this part of the study then. So they're slowly, and we hope that we'll still be able to have that arm of the study, but it's going to take some time.
Yeah, so talking about this device, what the left-ventricular assist device is, it's a little bit different than the total artificial. So this is a surgically implanted mechanical pump that it either helps or it completely takes over the job of the left ventricle of the heart. So it's taking the blood from the left ventricle and it's pumping it to the aorta, that blood is going to the body. And then the drive line here is a cable that exits the body through the abdomen, and then that is connecting to the power source, which is what was in that backpack. And that's allowing for the control and the power of the pump itself.
And so for an LVAD, if the driveline's exiting the abdomen, typically then they'll have a controller that they're wearing around their waist, and then typically the controller would be connected to a battery on the left and the right hip, carried like that or in pockets. And so patients have been creative in the ways that they are going to wear clothing. I know one gentleman who puts them in Zuba pants because he wants to hide those batteries. Then there's some women that sew their own vests, and there's some people that buy fishing, hunting, or shooting vests to carry their equipment as well. So this is going to be just a little video to tell you a little more in depth about an LVAD. Karin and I do not have stock in any of the companies whose videos we're showing you today. So for disclosure, we are not, and all these are FDA approved for what they're being demonstrated.
Thoratec, the leader in mechanical circulatory support, introduces the HeartMate 2 Left-Ventricular Assist System. The HeartMate 2 is a small and quiet advanced blood pump designed for improved outcomes with a wide range of late-stage heart failure patients in need of reliable, long-term circulatory support. 60% smaller than currently approved implanted electric pulsatile LVADs and weighing only 400 grams, the HeartMate 2 incorporates precision engineering, a simple design, and 30 years of clinical experience. It is intended for long-term support as a bridge to transplant or for permanent implant known as destination therapy. The HeartMate 2 is implanted just below the heart. The flexible inflow cannula is attached to the apex of the left ventricle, and the outflow cannula is attached to the ascending aorta. The HeartMate 2 pumps blood from the weakened left ventricle to the aorta, the main artery feeding blood to the entire body. The flexible inflow cannula is designed for a wide range of patients, accommodating changes in anatomical position and allowing the inlet to remain centered in the ventricle. Both the inflow and outflow cannulae feature textured blood contacting surfaces clinically proven on the HeartMate XVE to be thrombo-resistant. Utilizing advanced continuous flow technology, the HeartMate 2 has only one moving part, a small spinning rotor that is capable of providing flow from 3 to 10 liters per minute, covering the full cardiac output of a healthy heart. As blood enters the pump, seen here in slow motion, it is straightened by the inlet stator veins prior to entering the path of the rotor. The rotor then spins the blood radially and propels it toward the outlet, where blood flow is straightened by the outlet stator veins.
So I think that's enough to give you an idea of how advanced this technology is, and I am not researching as an engineer. I'm clinical application, quality of life. I'll just tell you briefly, there's been a few generations of LVAD. So the first ones were pulsatile, and then there's the LVAD 2 with a continuous flow. And there were a lot of problems with thrombus formation and GI bleeding. So now we've actually come to the generation of HeartMate 3, and it's maglev technology, so you don't have the contact with the blood, and we're seeing a lot fewer stroke incidents. And unfortunately, when they took a look at the quality of life outcomes, which were measured with heart failure questionnaires, not LVAD-specific questionnaires, they saw no significant improvement, despite the fact that they had seen a significant reduction in some of the stroke and other kind of more clinical indicators. And so what that speaks to is we don't have a sensitive enough measure for quality of life among these patients, and they will tell us this themselves. So why would you get an LVAD bridge to transplant when you're waiting for a heart? Destination therapy, you're not a candidate or you don't want a heart transplant. Perhaps you're older and you've had metastatic cancer and you're going to have this in your later years. Bridge to recovery and bridge to decision. So these are, or bridge to candidacy is another term you're going to hear. So we are realizing we don't actually know for some patients when that left ventricle has been offloaded how much is actually going to recover. And so there have been some real helpful cases where we've seen that the left ventricle has been able to recover as well. And then they don't need transplant. So here's an x-ray. This is not the x-ray of the same person here, but it's just showing you the technology that might be This person actually has another device. They have implantable defibrillators and biventricular leads for heart failure as well. But this is the device itself, the LVAD coming off the left ventricle and then pumping out to the aorta. And then just wanted to show you an example of how a gentleman might be carrying his equipment. So he has a vest and he's showing how he's supporting his controller and his batteries there. So this is a gentleman who is not a patient. There's no confidentiality issues here. This is a friend who signed off on being videoed to show us.
Okay. To start with, this is the harness that I use. It's made out of mesh. Keeps you nice and cool during the summer. Easy. You have batteries that are hooked up to it, one on each side. They haven't been parallel, so that if you lose one battery power, you still have power to your pump. And inside the case, this is what your battery looks like. This is the connector and the wire that goes down to your controller. Okay, we're going to put this away. And at the controller then, you have your two lines coming in, one from each battery. They power the controller and run the electronics that control the pump that's inside of you. This is the line that goes from the controller, goes through the skin inside to the pump.
Yeah, so just talking through some of the risks with placing an LVAD. Obviously, there's surgical risk for going in and placing the device, as well as infection risk with the driveline coming out of the skin, the device failure possibility, and then just other complications with the perfusion of the heart.
And the complications have gotten incredibly better in recent years, and especially with the HeartMate 3 as well. So now that you've seen a couple people with an LVAD, what would be your questions, concerns, or maybe happiness about how your quality of life might be affected with an LVAD?
How do you take a shower?
How do you take a shower? That is the number one thing that tends to come out when we talk to people. It's a pain. So you're not allowed to have a shower initially after surgery for a little while. It might be a few weeks. And different sites have different policies. But the important thing is to keep that driveline clean and avoid infection. So you're not allowed to take a bath or go swimming and immerse in water. And you have a bag, a shower bag. You put your equipment in. And then you're doing dressing change right afterward. So it takes quite a while. It feels cumbersome at first learning that, and a lot of our male patients are having their significant others help them with this. And we've had a couple male patients who say, oh, they never do their dressing changes themselves. They always rely on their caregiver, which is a very interesting phenomena that we're seeing as well. They never actually do learn how to do that. Yeah. Any other comments about that? So different sites have been trialing and researching different measures for dressing changes too. Anything else?
Has it affected, how does it affect people's sleep?
Sleep. How does it affect your sleep? So for some patients, they might, if they've had heart failure for symptoms that were noticeably severe, and they would to get an LVAD, they're going to actually be perhaps sleeping better because they can actually lie flat to sleep instead of sitting up in a recliner. And then for some other people, they might find it uncomfortable if they sleep with a partner. And that gets into the whole subject of intimacy as well, because it takes a space in the bed, and it might be between them and their partner. Any other thoughts or about living with an LVAD that might affect your quality of life? So we'll go on. We'll share a little bit about some of the things we were hearing.
Yeah, so talking a little bit more about quality of life and how it varies from person to person. These two men are both 40-year-old men. They're both ex-military, but they have very different perspectives on their LVAD. So this man described it as, it's not a death sentence. You don't see yourself as a victim. If you work hard and see past the sacrifices you have to make, the new normal is the same thing as your old normal. Whereas this man said, I'm 15 seconds away from death at any time. My life ended when my heart failed. This machine allows me to exist, but not to live. So these two men, very similar backgrounds, have very different understandings of what they want and their quality of life. which is why this is such an important thing to be looking at for these different patients.
And challenging to measure. So that's why we chose Qualitative. I will just say both of these men had their blogs on the internet. So in the past, quality of life had been measured, I would say, incorrectly with objective criteria such as mortality, morbidity, return to employment, and then more recently in the last several years using measures that were generic like the Euroqual or heart failure specific quality of life measures like the Kansas City cardiomyopathy questionnaire or the Minnesota Living with Heart Failure. So these are really helpful for the heart failure, and you're going to see pre to post LVAD outcomes incredibly improved. My quality of life is better, I can breathe better, I'm not having chest pain, my swelling is gone. But it doesn't get into specific areas that are impacted by having a line coming out of your belly or not being able to immerse in water or things that made your sleep or your relationship or your intimacy better or worse. So when I started in this area of research years ago with Dr. Barb Hoagland, the patients just basically told us in the interview we want our own questionnaire. I actually got permission to show them a couple other heart failure questionnaires, and they actually shoved the questionnaires back across the table to me, and they said we need our own questionnaire. So we began to develop one with them. So our definition that came out of those interviews initially in 2014 is quality of life is well enough to do and enjoy today activities that are important to me, and that's going to vary depending on who you are. So we developed this conceptual model based on some interviews that we published in 2014, and with our perspective, quality of life through those interviews came very consistently to consist of 5 domains in life. And they are going to intersect and they're going to affect each other, and those are dotted lines. But physical, cognitive, social, emotional, and spiritual. And then there's examples. So this is the model that we feel is subjective because it's the patient's perspective, and it's going to vary on their circumstances. It might change next week. And it's multi-dimensional, which is what we're measuring. So is there any language in the Bible? What difference does it make that I am teaching at Bethel University, a Christian background, Judeo-Christian beliefs? Does it make any difference? Does it influence the way that I research? Well, I would say yes, because I'm going to look and see if the background, what I have believed in terms of philosophical and faith-based perspectives aligned with the conceptual framework that we developed. And so I was taking a look years ago at Luke when the very educated religious leader asks Jesus, what do I need to do? And Jesus said, you must love the Lord your God with all your heart, soul, strength, mind. And it seems that you could make a case that these are then supported by emotional, spiritual, physical, and cognitive domains of a person. And then when you add the next phrase, and you love your neighbor as yourself, that would include then the social dimension of a person. So we are multidimensional human beings. Is spiritual well-being important in LVAD patients? Do we have any evidence to support this? Well, prior to our work, there was only one study that I could find that looked at spiritual well-being among patients with an LVAD. And this was using a generic questionnaire by Carol Farron's, work done by Kathy Grady, who does amazing work in quality of life and LVAD out of Chicago. And it did seem that spiritual well-being was one consistent measure throughout the study. Patients, if they came in with strong, they left with strong. If they came in low, they came in low. And that's actually that actually kind of makes sense as you look at literature in other areas as well. So we found that spiritual well-being or meaning, like my purpose in life, was discussed enough that it was legitimate to put it in our conceptual model. And then in April here, in our quantitative study of 186 LVAD patients from 7 sites, in which we used our QualVAD questionnaire, we did find a strong inverse correlation between spiritual well-being and depressive symptoms. So someone who had stronger spiritual well-being had fewer depressive symptoms, and vice versa. Now, this is not a randomized controlled trial, so we cannot say this caused that. Okay, but we're looking at an association that was statistically significant, and so I think we do need to explore this area, and we do have support that it is an important dimension to be measuring and potentially finding interventions for in our LVAD patients. So how did we work just the methods here. A qualitative approach with semi-structured interviews, and so the interviews were conducted at Cedars by their staff that were qualified researchers. They were given or took a code name. So in all the interviews that were audio taped, and they had fun. One man wanted to be called Superman. That was the code name that he took, and another was Mr. Winkle. So they kind of had fun with their code names then. They were audio recorded and then was transcribed by a professional transcriptionist. And then this is where we had weekly phone meetings where we developed a code book and then continually revised it because we had topics and then we had subtopics, and we wanted to be consistent with that code book here in St. Paul, Minneapolis with our patients as well as the caregivers, so that eventually when we triangulate, we will be using the same codes. And I'll just briefly show you what we used. Atlas is a qualitative software program. And this is how it looks, and we had a lot of fun learning this. This was new to me. The first time I had done qualitative, it was all hand coding. So that's been fun to learn. Okay, and getting back to Karin. You might have to help me get back to our main slide here. So this work can be done remotely, and we did have a guidebook that gave us some guidelines on how to work remotely at different sites. So we had the 12 patients, and they were mostly men, and that does, it is fairly similar to the patients that have LVADs when you look nationally at the Intermax database. And what we're really excited about was we did have some diversity in the sample, which we probably would not have had if we were here at our site here. So you can see diversity both in ethnic cultural background as well as time since implant. We had some variation there, and age and years of heart failure. So preliminary findings.
So yeah, just going over some of the things that we found the first time through coding all of this qualitative data. These are just some of the quotes that we pulled from those transcripts. So talking about spiritual and emotional, but I'm not really a religious person anymore. I'm a spiritual person because when I was in the hospital, when they say, when you die, you see things, I did see things. Maybe it was in the medication or what, but it opened my eyes more to what could happen if you don't believe in something. Was a quote from one patient, and another one, my poor wife is 24/7 taking care of me, so I don't know if it is better if I die and then she doesn't have to take care of me, or if I could live like this, I don't know. But I was not expecting this kind of reaction. So really trying to take in word for word what these patients are saying about their experience with an LVAD and through that process with their caregiver as well.
And you can see the overlap, the spiritual and the emotional domain, as well as the potential impact on the caregiver then.
And then in terms of the social domain, but as far as the intimacy returned, because before there was no intimacy, because I couldn't do nothing.
He's talking about sex.
I was out of breath and just no blood flow, just terrible. So since the device has been implanted, all of that's returned. So this patient's talking about the positive impact of this device. Like I said, I know she's hesitant sometimes because she's scared. I don't want you having a heart attack, and I don't want you passing out. I said, if I'm going to have a heart attack that way, let me go with a smile on my face. That's a good way to go out.
So patients are weighing, right? They are weighing pros and cons, and they are weighing what is important to them and what risk will I take to have the benefit that's important to me. So this is going on all the time. So we did use some kind of just very practical, pragmatic topics as the overlying categories. For example, spiritual, because we were following that model. Showering came up a lot, and then the devices being heavy and the batteries being heavy, particularly women, and that's why we're hoping still to get some more perspectives of women. And then for spiritual and meaning, definitely heard about faith and faith support, as well as fellow churchgoers support. We had a couple pastors actually in this sample, as well as some very interesting discussions about whether God was testing me or not. And then support groups were very helpful when available. One of the challenges with LVAD patients at large medical centers is that they're coming often from outlying areas 2-4 hours away, and then the communities where they are at don't necessarily have a support group for LVAD patients, where they might have a heart failure support group, and it's all old people, and you're a young person. So this is something that we're also trying to figure out, how can we help meet that need as well. And then as our colleagues in Cedars found out, really the caregivers might be the ones that have been neglected. So as we look at spending our time and funding on the patients, we have caregivers in the interviews explaining how they feel like they have actually lost themselves or become invisible in this whole process then. And some of them are saying, I had no idea, I did not sign up for this, and there's sometimes regret. And surprise, and sometimes they're feeling like one thing that came across was policing, taking away the salt, making sure their loved ones, and that wasn't what they signed up for in a marriage.
So as for the potential impact of the study, we really just want to begin to open up this idea of understanding quality of life for these patients, as well as their self-management. So really trying to bring together the research that we found as well as what's already out there, and apply that in some sort of clinical setting, and continuing to address the different topics that need to be addressed for the different device companies that are moving forward with creating maybe a lighter device or a device that is quieter, or different things that patients are asking for that they're unsure of at this point.
So obviously we are hoping for research utility with quantitative measures, and also findings to augment them in our qualitative studies, but we also are looking for clinical utility. And so the LVAD clinician to be able to say, here's what I'm hearing from patients who are 4 months out, or caregivers in the first month, to be able to help them know this, to normalize perhaps some of what they're experiencing and to prepare them as well. And potentially, I know some LVAD clinicians that want some more of this data to help with patient and provider decision-making on if they're gonna have an LVAD or not to them. And then with the work being done at Cedars, a greater understanding of their caregiver role as well, so that they don't feel like they have lost themselves or become invisible. So education would be important, as we mentioned, and also for further development of support. So in order to provide support, exercise, support groups, that cost money. So even having spiritual care, that costs money. So where's that going to come from? Unless we have evidence to say this is important, it impacts the patient, not having it could have adverse outcomes, then that might not get as much funding or as much even rooms or support or strategies. And so given that we are seeing the findings we have some support for hospitals and clinics to consider what counseling should be available maybe for the caregivers, and what maybe can be done with peer-led support groups, as well as the topics for them, and also even just having spiritual care as part of the LVAD team then. And then where does end-of-life discussion occur as well, for especially some of the older patients who want to have this discussion, but maybe even feel guilty bringing it up because their surgeon went to so much work to put in the device. So where does that all fit?
Yeah, and then something that we had mentioned that we've seen with a lot of these patients is a lot of them just want to be able to talk about their situation. They want to talk with someone that understands what it's like, because this patient population with LVADs is a smaller population of people that are living with this. There's not as much opportunity for them to be able to do that in their day-to-day. So these support groups, both online and in person, have really been something that patients have talked about as a really strong source of support, to be able to talk about ideas of different ways to carry your device, or different ways to put it underneath your clothing, and they can talk about those things and figure out and share different ideas about that. So that's been something that's been a theme throughout this study of a strong place of support for a lot of these patients.
Right, and we have such intelligent, strong patients with LVADs that have so much to teach us, so and teach each other. So we're presenting the Vanishing Caregiver that was presented here this spring in Orlando at the International Society of Heart-Lung Transplant. And then we anticipate finishing our manuscript to submit this year on the patient perspectives. And then we will join together to look at kind of triangulating the data probably in 2020 with Cedars as well. Questions, comments?
I have one question. How difficult is it to get on commercial flights?
Oh, how difficult is it to get on a commercial flight with an LVAD? A few years ago, it was extremely hard and would cause frustration and anger for the patients. They would have the note from their doctor, they would have the equipment labeled, and security would say, okay, take off your bag, take off your fanny pack. It doesn't come off. It's connected in my belly. And so these days there seems to be an increasing awareness from what I've heard from patients as it becomes a little bit more known. But that was a real struggle. Anything else? Well, thank you so much for coming today, and we're excited to continue to learn from these patients and hear what they have to teach us. And it's been a joy to work with Karin. I don't know if you know, but Karin's background, she has a business minor. So she comes at this research in a really fun perspective because one of the things she did right away was to compare and contrast the different companies making these devices, kind of from a business perspective of what they provided that someone didn't provide. So I'm really excited to combine kind of the healthcare, nursing, research, and business. Thank you.